Welcome to The Explainer. Today, we're diving into what looks like a common childhood injury, but is actually a high-stakes mechanical puzzle. We're going to take a fascinating look at the medical mechanics of the pediatric elbow, and specifically, those really intense, high-pressure decisions surgeons face when things break.
Okay, so picture this. It's 3 a.m. An 8-year-old comes into the ER with a massively swollen elbow from an injury just 3 hours ago. The clock is ticking. You can still feel a pulse, but you have a huge decision to make. Do you reduce it, meaning physically snap that bone back into proper place right now, or do you wait? If you slap a splint on it and wait for the swelling to go down in a couple of days, or just let the patient sleep to tackle it the next morning, you might lose precious time. But man, operating in the middle of the night has its own massive risks.
So, to understand how surgeons navigate this incredibly tricky environment, we'll be looking at the swollen elbow dilemma, classifying the fracture, tricky fracture patterns, restoring the anatomy, protecting nerves and vessels, and finally, avoiding surgical catastrophes.
Let's start with Section 1, the swollen elbow dilemma, high stakes at the hinge.
To really grasp the stakes of that 3 a.m. decision, we need to look at what exactly is breaking here. Look, this isn't just any broken bone. We're talking about a supracondylar fracture, which is actually the single most common elbow fracture in kids. And it happens at this incredibly narrow, razor-thin, unstable area right between the olecranon fossa and the coronoid fossa. Because this spot is literally the thinnest, most vulnerable part of a child's elbow, trying to stabilize it so it heals correctly, it's an absolute nightmare.
And that brings us right back to our surgeon's massive dilemma. Do you risk operating on a highly swollen arm right away, or do you wait and risk further complications with the alignment? And it doesn't stop there. When surveyed, medical pros face a really tough choice on how to physically pin the bone back together. Do you go with 2 lateral pins, maybe 3, or a mix of medial and lateral? Now, overwhelmingly, the most common survey choice is using just 2 lateral pins in a closed procedure. But as we'll see in a minute, every single one of these choices carries its own unique set of risks.
Moving on to Section 2, classifying the fracture, reading the clues.
So, before a surgeon even touches a pin, they have to classify just how bad the break is, using something called the Gartland classification system. Think of it as building from a minor issue to a full-blown crisis. A type 1 is an undisplaced fracture, meaning, the bone hasn't really shifted out of place. It's often diagnosed just by spotting a really subtle fat pad sign on the x-ray. Type 2 gets a bit sketchier. It's an angulated fracture, but thankfully, the posterior cortex of the bone is still intact. And then there's type 3, which is a completely displaced fracture. The bone is fully separated. Yikes.
But what's really fascinating here is the recently added type 4. This is a notoriously unstable variant where the internal hinge of the bone, the periosteal hinge, is completely destroyed all the way around. It's totally gone. When a surgeon actually tries to reduce it while looking at an x-ray screen, they'll see the bottom fragment of the bone wildly flexing forward and extending backward. Because that hinge is just circumferentially useless, standard maneuvers won't do a thing. It makes fixing this break unbelievably tricky.
Next up, Section 3, tricky fracture patterns, finding the outliers.
Now, beyond those standard types, surgeons have to keep their eyes peeled for rare clues that completely throw the standard game plan out the window. For example, 98% of these injuries are standard extension injuries, but there's a tiny 2% slice that are flexion types. But hey, don't let that tiny number fool you. This rare fracture is incredibly dangerous because it is highly associated with severe ulnar nerve injuries. It's way more unstable than your standard break, and surgeons are strongly advised to meticulously check for nerve damage both before and after they try to fix it.
Surgeons also have to hunt for sneaky hidden dangers. If you spot medial comminution on an x-ray, which is basically medical speak for the bone being shattered or fragmented on the inside edge, that's a huge red flag. It implies there are hidden rotational misalignments going on. Even if the main fracture looks perfectly in place, that inner fragmentation means it demands extra, super tight fixation, sometimes even needing pins on the medial side too. Oh, and if the fracture line isn't a simple straight break, but an oblique angle, that completely changes the pinning choices. And the geometry here? It's totally unforgiving. If a surgeon misses an oblique angle of more than just 10 degrees in the coronal plane, there is a massive risk of malunion. That means the bone heals wrong, permanently altering the actual physical structure of the child's arm. And get this, the math gets even stricter when we look at the sagittal plane. In that view, anything over a 20-degree obliquity is pretty much a guaranteed recipe for poor healing. Margins for error? Basically zero.
All right, Section 4, restoring the anatomy, engineering the fix. So now that all the clues are gathered and they know the exact angle of the break, the real mechanical engineering phase begins. Remember that wildly unstable type 4 fracture we just talked about? Yeah, routine pushing and pulling isn't going to cut it. Instead, surgeons actually take a surgical pen, a K-wire, and they use it literally like a video game joystick. They stick it directly into the broken piece of bone and use it to physically steer and align that unstable fragment into perfect position from multiple angles before driving the final fixation wires in. Honestly, sometimes it takes up to 3 wires just to lock down this specific chaotic fracture.
Once they finally got it aligned, the surgeon runs through a rigorous checklist of geometry and live imaging. See, the humerus bone naturally tilts forward, so the pins have to be driven from front to back at a really precise 10-degree angle to line up both sides of the elbow. Then they confirm the geometry using Bauman's angle and the radiocapitellar angle. But here's the absolute biggest pro tip. To check these angles, the surgeon has to rotate the giant X-ray machine entirely around the arm. You absolutely cannot twist the elbow itself. Twisting that fragile little elbow just to get a better picture will instantly ruin the delicate alignment they just spent all that time perfecting.
Which brings us to Section 5, Protecting Nerves and Vessels. Navigating the minefield.
Driving sharp metal pins into a tiny, swollen child's elbow is literally like walking blindly through a minefield of vital nerves and blood vessels. And the biggest, scariest landmine? The ulnar nerve. Naturally, it sits right behind the medial epicondyle. But here is the truly terrifying part for a surgeon. When the arm is bent past 90 degrees, that ulnar nerve physically shifts its position and moves forward. Trying to blindly pin the bone without being able to feel exactly where that nerve went in a swollen arm, incredibly hazardous.
To dodge this, surgeons will often skip the standard medial pinning approach in favor of the short shot method. See, with standard pinning on a tiny, swollen elbow where you can't actually feel the nerve, you risk skewering it right on the pin. No thanks. The short shot method completely flips the script. The surgeon makes a tiny little incision and passes the wire while the arm is held in a much safer semi-flex position. But they only do this after the outside, the lateral side, has already been completely locked down. And then there's the Dorgan pinning technique. This one goes from top to bottom, and precision is everything. The pin has to enter from the back outside corner within exactly 2 centimeters of the lateral epicondyle. But here is the absolute golden rule. That pin must stop exactly 2 millimeters short of the inner edge. 2 millimeters. If you push even a fraction too far, you hit the nerves. It is a literal game of millimeters.
Finally, Section 6, Avoiding Surgical Catastrophes. The final verdict.
At the end of the day, successfully solving this crazy mechanical puzzle comes down to prioritizing exactly what can go wrong. Surgeons literally divide the risks into 2 buckets. On one side, you have the absolute catastrophes you must avoid at all costs, like cutting off the blood supply or causing compartment syndrome, which can literally destroy the whole limb. On the other side, you do your absolute best to minimize what they call embarrassments. These are things like accidentally causing nerve damage with your own pins, or leaving the kid with a cubitus ferris deformity, which is basically a permanently crooked arm.
This whole mindset perfectly captures the philosophy of the legendary orthopedic master, Mercer Rang. He framed this entire surgical procedure not just as a mechanical fix, but as a high-stakes exercise in risk management. You have to respect the anatomy, know the exact fracture type inside and out, and never, ever forget about the soft tissue surrounding the bone.
So we'll leave you with this thought. Knowing the razor-thin margins of an 8-year-old's elbow, the hidden nerves that physically move around, and the incredibly strict geometry required for the bone to heal, how would you balance the perfect mechanical fix with dodging those hidden anatomical landmines? It's a truly remarkable feat of everyday medical engineering. Thanks so much for joining us for this explainer, and keep questioning how the pieces fit together.